Hello everybody, welcome back. Today our topic is a major public health threat, which is responsible for millions of fractures annually, mostly involving the lumbar vertebrae, the hip and wrist, and is also responsible for fragility fractures of ribs in men. Today our topic is osteoporosis. The defining feature of osteoporosis is a reduced bone density, which causes a microarchitectural deterioration of bone tissue and leads to an increase in the risk of fracture. The prevalence of osteoporosis increases with age, noting that the bone density declines with age, especially in women. Fractures related to osteoporosis are estimated to be around 30% in women and 12% of men in developed countries. They affect 30% and in men 12%, which shows that in women is more than double that of men. Osteoporotic fractures can affect any bone, but the most common sites are 1. The forearm, which the fracture is called Colles fracture, the spine, the fracture is called vertebral fracture, and the hip. Noting that hip fractures are the most serious kinds of osteoporotic fractures. Treatment of hip fractures accounts for the majority of the healthcare costs associated with osteoporosis. Now let's talk about the pathophysiology of osteoporosis. Osteoporosis can occur because of a defect in attaining the peak bone mass, plus minus an accelerated bone loss. In normal individuals, bone mass increases during the skeletal growth to reach a peak maximum between the ages of 20 and 40 years, but then it declines. In women, there is an accelerated phase of bone loss after the menopause due to estrogen deficiency, which causes uncoupling. Uncoupling of what? Uncoupling of bone resorption and bone formation. Age-related bone loss accounts for gradual bone loss that occurs with advancing age in males and in females. Bone resorption is not particularly increased, but bone formation is reduced, and bone formation in that case fails to keep in pace with the bone resorption. In osteoporosis, accumulation of fat in the bone marrow space also occurs. Why is this accumulation of fat in the case of osteoporosis? Because of an age-related decline. There is a decline in the ability of the bone marrow stem cells to differentiate into osteoblasts, and it increases in their ability to differentiate into adipocytes. And this differentiation into adipocytes account for the accumulation of fat in the bone marrow space in the case of osteoporosis. Peak bone mass and bone loss are regulated by both genetic and environmental factors. Let's start talking with the genetic factors. Polymorphisms have been identified in several genes that contribute to the pathogenesis of osteoporosis, including 1. Estrogen receptor, the ESR1, 2. The lipoprotein receptor related protein 5 gene, LRP5, 3. The genes that encode osteoprotein, rank, and alpha-1 chain of type 1 collagen. However, these account only for a small proportion of the genetic contribution to osteoporosis, and many genetic variants remain to be discovered. So now let's talk about the environmental factors. Environmental factors such as exercise and calcium intake during growth and adolescence are important in maximizing peak bone mass and in regulating rates of postmenopausal bone loss. Smoking also has an effect on bone mass density and is associated with an increased fracture risk. Heavy alcohol is a recognized cause of osteoporosis and fractures. Let's talk about postmenopausal osteoporosis. Menopause is the most common cause of osteoporosis because of the effects of estrogen deficiency, as we mentioned before. Osteoporosis in men. Osteoporosis is less common in men, and in about 50% of the cases, a secondary cause can be identified. The most common are 1. Hypogonadism, 2. Corticosteroid use, 3. Alcoholism. In hypogonadism, the mechanism is that testosterone deficiency results in an increased bone turnover and an uncoupling of bone resorption from bone formation. What about the corticosteroid-induced osteoporosis? Corticosteroids is an important cause of osteoporosis, which relate to the dose and duration of this corticosteroid therapy. Although there is no safe dose of corticosteroid, the risk increases when the dose of prednisolone exceeds 7.5 mg daily and is continued for more than 3 months. Corticosteroids have adverse effects on calcium metabolism and bone cell function. In corticosteroid-induced osteoporosis, bone formation is reduced due to a direct inhibitory effect on the function of osteoblasts and due to the steroid-induced apoptosis of osteoblasts and osteocytes. Corticosteroids also inhibit intestinal calcium absorption and cause a renal leak of calcium, and this tends as a result to reduce the serum calcium, leading to a secondary hyperparathyroidism. What about pregnancy-associated osteoporosis? Pregnancy-associated osteoporosis is a rare condition that typically presents with 1. Back pain, 2. Multiple vertebral fractures during the second or third trimester. The cause of pregnancy-associated osteoporosis is unknown, but may relate to an exaggerated bone loss that normally occurs during pregnancy in patients with already pre-existing low bone mass. Thank you for watching and looking forward to see you in the next video with a new topic.